Okay, so good morning to everyone. My name is Neil Franklin. I am a 34-year law enforcement and veteran from the state of Maryland and the past executive director from the Law Enforcement Action Partnership. So I welcome you to this morning's session. For some of you, it is very early in the morning. And for some of you, I'm sure it is probably a little later in the day, depending upon where you are in the world. But anyway, thank you for tuning in this morning. I'm here on the East Coast in the United States, actually in Fort Myers, Florida right now. This session, Closing the Racial Divide in Healthcare and Policing, the journey from cultural awareness to transformative action. And we have some great presenters for you today. I'm just going to cover a little bit about what this session is about. So I'm going to read a brief statement that some of you have seen. The World Health Organization declaration of COVID-19 of the pandemic on March 11, 2020, and the murder of George Floyd at the hands of police on May 25th, 2020 were parallel in awakening the moral consciousness of healthcare professionals and criminal justice practitioners. The disproportionate number of deaths caused by COVID-19 in communities of color, and the spotlight focused on police brutality and the senseless killing of George Floyd, who was a 36-year-old African-American man. They have glaringly illuminated the systemic racism in the United States health system and in the daily ethnic health and and in the daily exercise of law enforcement and criminal justice. There is no debate. Racial and ethnic health and healthcare disparities have been documented for decades. People of color have been victims of unconstitutional and overzealous policing that has continued unabated since the slave patrols, resulting in over-incarceration, death, and traumatized communities. This session will explore concrete actions on a community level to engage a broad coalition of stakeholders, including police, to address inequities faced by people of color in securing cultural, competent healthcare, the fair administration of justice, and safety and security for all members of society. So we have some very talented folks from both of those areas, healthcare and policing, law enforcement here in the United States. So I'm going to begin with a brief bio of our presenters today, beginning with Ms. Sheila Thorne. Ms. Sheila Thorne is president and CEO of a New York-based multicultural healthcare marketing group. She has been recognized as one of the nation's leading thought leaders in health disparities and an cross-cultural educator in global cultures. Published in numerous health, trade, and consumer health publications, she has worked in communities of color throughout North America, Latin America, and Western Europe. She is associate clinical professor at Stony Brook University School of Social Welfare, served as adjunct professor at Quinnipiac School of Medicine, and is an annual guest lecturer on cultural competency at New York and Rutgers universities. More than 2 decades, Sheila has received awards for her unique ability to mobilize and galvanize communities of color, patient advocates, health providers, and justice practitioners around social justice and health equity issues. And I'll tell you, from what I know of Ms. Sheila Thorne, there's a lot more that could be included in this bio. She is just phenomenal. So thank you, Sheila, for being here. Next, we have Commissioner Giles Shipp, who I've known for a very long time. Mr. Shipp is Commissioner of the New Jersey Police Training Commission and has spent over 25 years in law enforcement as a police officer in Edison, New Jersey, an emergency response team member, and instructor at the Middlesex County Police Academy. Mr. Shipp was previously the lieutenant and administrator of investigations in the Division of Criminal Justice at the State of New Jersey Office of the Attorney General. Mr. Shipp also served as Director of Public Safety for the city of Plainfield, New Jersey. As the Chief Executive Officer of the Department of Public Safety, Mr. Shipp oversaw the Police Division, Fire Division, the Office of Emergency Management, and was responsible for 254 sworn personnel and 51 civilian employees. Mr. Shipp is the past president of the National Organization of Black Law Enforcement Executives and has been recognized for his service in innovation and policing by multiple civic associations, the state of New Jersey, Congress, and the Department of Justice. He holds an MA in Education Administration and Supervision from Seton Hall University and a BS in Administration of Justice from Thomas Edison State University. Mr. Shipp now teaches as an adjunct professor at Rutgers University School of Criminal Justice. And again, Mr. Shipp also has a lot more that could be added to that bio as well. And then last, but definitely not least, we have Dr. Ron Bailey. Dr. Bailey is the chairman of the Department of Psychiatric and Behavioral Health at Wake Forest Baptist Medical Center, where he has been since January 2015. Dr. Bailey was chairman and professor of psychiatry at Meharry Medical College, Tennessee from 2008 to 2014. He also was executive director of the Lloyd C. Lam Mental Health Center, the largest mental health center in Tennessee. He has had over $3 million in annual grant funding. He also served as an adjunct professor in psychiatry at Vanderbilt University School of Medicine. Before joining Meharry, he was medical director and chief executive officer of Bailey Psychiatric Associates for 9 years. Native of Texas, Dr. Bailey received his medical degree from the University of Texas Medical Branch at Galveston and completed his residency in psychiatry at the University of Texas at Houston, Texas Medical Center affiliated hospital, where he was the chief resident. He completed a fellowship in forensic psychiatry at Yale University's Department of Psychiatry in New Haven, Connecticut. He has over 50 reviewed articles, 45 academic grand rounds, and 4 book chapters published. But he also has over 40 publications, including a book entitled A Doctor's Prescription for Healthcare Reform, discussing healthcare disparities. He has served as president and a member of the board of trustees of the National Medical Association and as president of the Tennessee State Psychiatric Association. Let me tell you, he's got a ton of certifications here dealing with psychiatry and so many more things to his credit. He has done a lot of work over many years. So those are our 3 fantastic presenters today. And again, we're going to begin with Ms. Sheila Thorne, who's going to open with a presentation, then we'll move to Mr. Shipp, and then we'll round up with Dr. Bailey, and then we'll go into some Q&A. So hold on to your seats. You're going to experience just a wonderful session today. So thank you. Sheila, it's all yours.
Thank you so much, Neil. Good morning, good afternoon, or good evening, wherever you are. It's a pleasure and an honor to be here. I've known the gentleman on this panel for quite a long time, and I'm privileged to be a part of this conversation. Bring up the slides, please.
Okay. Are they there? Can you see them?
They are there. Thank you very much. Great. The next slide, please, Neil. As Neil said in his opening remarks, on March 11, 2020, the World Health Organization Director General declared COVID-19 a global pandemic. A little more than 2 months later, an African-American man, 36-year-old George Floyd, was senselessly killed at the hands of police in the streets in Minneapolis. These 2 seemingly unrelated events ignited an international response. because they helped everyone to focus yet again on the pervasive and persistent inequities and inequalities in American society. On a massive scale, the scientific community rallied together to find cures, treatments, vaccines for this novel coronavirus. And unfortunately, the world of justice practitioners continue to be horrified at what happened to George Floyd on that day of May 25th, because it certainly illuminated the violation of human rights of African Americans in the American society. Next slide. As the coronavirus made its way around the world, healthcare professionals, public health advocates were not surprised when the rates of infection, hospitalization, and deaths skyrocketed in the African American community, the Hispanic Latino community, and the Native American community. Because this has been the health profile of African Americans in particular. African Americans get sick more frequently, they're screened for illness less often, they're diagnosed later, they're treated less aggressively, and they're buried earlier than any other ethnic group in America. So clearly, the health disparities came clearly to the fore when the pandemic hit these communities in a dramatic way and continue to do so in the United States. Next slide. So the health disparities became an issue that became re-energized and recharged in conversations in public health arenas. Unfortunately, the first thing people point to about health disparities are no health insurance and poverty. Although those are two very significant factors, there's a whole constellation of issues that drive health disparities. Health disparities being differences in the burden of disease, morbidity, mortality, and prevalence. Healthcare disparities being the differences between access, outcomes, and certainly the level of insurance. So look at what's underneath the water that drives these healthcare disparities. So even if you're middle class and insured, these persistent disparities exist. Next slide. Here we come now to an era where there's much talk in the public health arena about social determinants of health. It is more a predictor of health outcomes in terms of your zip code than your genetic code. These are the factors that really drive health outcomes. And unless you address these factors, any intervention and strategies will be inadequate and insufficient. But take a look at the columns. Clearly, policing and law enforcement comes into play. Look at the column about neighborhood and physical environment. Underneath that, you see safety, you see walkability. That therein lies how the law enforcement community are protecting and serving us. If you scan over to the column of community and social context, we see exposure to violence and trauma. We see support systems and community engagement. That too speaks to the role of law enforcement in communities, especially disproportionately in communities of color. And then finally, healthcare systems. Clearly, cultural competency becomes a skill, becomes a mindset that we want both entities, public health and law enforcement, to embrace. How do you deal and work with people who don't look like you, who don't speak like you, who come from different places? Next slide. These disparities, health and healthcare disparities, are not new. The first time the government documented health disparities was in 1985, the famous Malone-Heckler report. Thomas Malone was a biostatistician at NIH who crunched the numbers. Margaret Heckler was the head of the then Health Education and Welfare Division of the federal government. This data supported now making healthcare more inclusive than exclusive, and set up the Federal Office of Minority Health and the state offices of minority health. Fast forward to 2002, and Congress commissioned the Institute of Medicine under the National Academy of Sciences to look at this again. And notice the title of the book, Unequal Treatment. That's language used in the civil rights legislation in the United States. So clearly between 85 and 2002, there have been a plethora of studies that all come to the same conclusion. People of color in the American society receive less than optimal care. And since 2002, there have been enormous data to support that same. In fact, the Unequal Treatment Report, the foreword says that those who studied this for 18 months were forced to conclude that people of color, even middle class and insured, do not receive quality health. Next slide. Then the American Public Health Association came into the front agenda of this whole issue as gun violence escalated, as there were more incidences like George Floyd, Breonna Taylor, even as far back as Amadou Diallo and others. The American Public Health Association saw that public police brutality is a public health crisis, and they entered the picture. So the intersectionality of health and healthcare disparities with law enforcement and policing became clearly to the forefront. And that's why this forum is being had today. We have to have both groups at the table if we're going to solve the human rights issues that are so prevalent with people of color, not only in the US, but around the world. And then among Black millennials, Black Lives Matter came to the fore. And initially, this group was demonized, vilified. They were labeled as domestic terrorists. Now they're naming streets and plazas after them and trying to put them in the front arena of the Pulitzer Prize for Peace. We've come a long way. But again, the two entities, public health and law enforcement, now have to come together to solve these persistent, pervasive problems of inequities. Next slide. I've had the privilege of working in communities throughout North America, Latin America, as well as Western Europe. And I see there are 5 areas that have to be addressed and we have to find solutions for. Lack of health information to these groups, health misinformation, not getting the right information that's culturally relevant, mistrust, distrust because of medical research abuse and microaggressions daily, undervaluing the impact of social determinants, which are the drivers for health outcomes, and certainly the cultural deficit of health providers. There are a number of states in the United States that now require cultural competency training as a condition of relicensure. So we are coming together. We have reached the tipping point where we must solve these societal inequities, both on law enforcement and healthcare disparities, so that everyone can have quality, affordable, accessible, equitable healthcare. It's not a privilege, it's a civil right. And clearly, if we want to lift up the human rights of all people, we have to bring these two entities together and talk about solutions. And I'll share some of the solutions that I've been able to be involved in over the last 2 decades as we go into our panel discussion. So thank you for your attention. I hope this has given you a picture of the landscape and why we're all here this morning.
Sheila, thank you very much for that great opening to our session this morning. And next we're going to go to Mr. Shipp. Giles, it's all yours. And don't forget to unmute yourself.
Yes, thank you, Neil. And it's a pleasure to be here because this is a most important cause that we're undertaking as it relates to mental health and as it intersects with policing. One of the things that we like to talk about in the profession, I call it somewhat of a more comfortable conversation, is social and as well as economic factors that impact law enforcement and how law enforcement interacts with the community. One of the more difficult discussions that we don't like to have is the relationship between African Americans ever since they set foot on this country and also the law enforcement community. And if you follow it, there's a specific history there. And that specific history goes always back to the slave patrols when they were created. And if you fast forward, if you move up to 1865 and the 13th Amendment with the Emancipation Proclamation, even though that was supposed to free people of African descent who were for over 250 years laborers, quite frankly, in this country without any compensation. At that point, they basically said, okay, we're going to free you, but we're not going to give you any land. We're not going to give you any type of other properties or anything that you would need to really coexist and be equal. So what happened after that? Black codes were created. And the reason why I speak to this, not only because of the impact that it has on individuals mentally, but also economically. And let me explain what I'm talking about. when the Black codes were created, those were codes that were created to basically still keep the Africans that came here as an underclass and continue to make them laborers, because you got to remember the South was decimated after after the war, after the Civil War, and there was no labor force. So what was done is that there were Black codes made to keep that group as an underclass. And who was on the front line of that? In most cases, it was law enforcement. Fast forward to the 14th Amendment, and we can go take it all the way to Plessy versus Ferguson, and it became separate but equal. So that's when the Jim Crow laws came into place. And some names I know many Americans may remember, such as Commissioner Bull Connors, Cecil Price, who was directly responsible for the death of Swerner, Goodman, and Cheney in the South, Philadelphia, Mississippi. You know, and there was others, many others who were in the law enforcement profession. So what did that create? That created a systemic problem that we still deal with today in policing, where a certain group of people are considered the other. And that has had a psychological impact on that group of people. And a lot of times we don't really want to deal with that aspect of it. And it impacts their mental health and how they view law enforcement and society in general. So, you know, those are some of the things that we need to continually talk about. And it's not just impacting people who are out of law enforcement and everyday citizens who work hard every day. It also impacts law enforcement officers, because there's this dichotomy between Black and blue. And are you Black or are you blue? And it has really manifested itself in some very tragic ways. If you remember recently in Louisiana, a police officer tragically took his own life because he was struggling to deal with that phenomenon. So the important aspect of what we talk about when we talk about the American African experience with law enforcement, it's totally unique to any other group that has ever had to deal with that. And I'm not a trained psychologist and definitely not a psychiatrist, but I can tell you from not only being in the field of law enforcement for over 34 years now, but I can tell you also as being an individual who grew up during the turbulent times of the 60s and actually seeing the impact that this has had on people, including myself. It's something that I couldn't be more happier that we're dealing with now, because it directly impacts not only the human psychic, but also if you look at the law enforcement profession from, I would say within the last 50 or so years, we went from the incarceration of approximately 300,000 people. Now we're at 2.3 million people that are incarcerated. And I would guarantee you that over 50% of those people who are incarcerated or get caught up in the criminal justice system are people that suffer from mental health issues. And as a group and as an organization, from the law enforcement side or criminal justice side, as well as from the mental health side, we have to deal with that problem. We really have to deal with that problem, because you always have to remember too, even if I consider it a temporary Band-Aid by putting someone away, they're eventually going to come back out. And what are we doing to our society if we're having people who are incarcerated and haven't been treated and haven't been given the care and consideration that they need, and then they come back out to society? It's going to be perpetual. So I just wanted to open up with that. I look forward to this discussion, and thank you for having me.
Thank you, Giles. I really appreciate that. And before we go to Dr. Bailey, I just want to throw something out here to our wonderful panelists to be thinking about. So when we get into the Q&A and discussion part, to be thinking about specific pieces of public policy that come into play historically and now, current times. that, public policy is obviously very significant to the systems of racism that we're dealing with and the effects of that. So just think about that, and we'll come back to I think it's important to talk about these pieces of public policy, and maybe some of our attendees to this session might be able to add some value to that too, and maybe even do something about that as we move forward in the future. So now we're going to go to Dr. Bailey. And Dr. Bailey, don't forget to unmute yourself. And whenever you're ready, I'll go ahead and pull up your slides. Just let me know.
Well, good morning. Welcome. I am ready. Ron Kennedy Bailey. I'm happy to join the group today. I'll be speaking on closing the racial divide in healthcare. I would add briefly, I fortunate to have been chairman both at Meharry those years from 08 to 2014 in Nashville, and at Wake Forest after that. I got that job in 15, but I'll be starting as the chair. I'm not even sure I told you on this yet. My third chair role, I'll be chair at a big school now at LSU School of Medicine in New Orleans, June 1st. So going deeper into the South, and I'll probably have more opportunities to work in this area that I think our earlier speakers have spoken on, because the reality is these are huge issues, I think, in our community, I think in these joint professions. As also mentioned earlier, I'm a forensic trained psychiatrist. I've been doing this work for 25 years. Similar to law enforcement, forensic medicine or healthcare law concerns are often addressed assessing individuals who may, due to mental health concerns, come into conflict or crosshairs with the criminal justice system or the legal system. There are a lot to, I think, say in that regard as well, to find ways to address strategies to help manage those concerns. That being said, I also have a lot to say, I think, in the question and answer, so the earlier points made, but let's go through a few slides. My first slide is entitled The Preschool to Prison Pipeline, and it really just begins with this idea that these issues of inherent structural racism really do start from the very beginning or inception of American life or American society for young African-American and Black and brown young person, especially young men. One study shows that this prejudice starts with 8 children in a preschool. Well, I trained at Yale, and in 2016, the Yale University Child Study Center examined implicit bias in teachers based on sex and race. That particular study showed teachers gazed more closely and longer and looked for longer periods of time at Black boys compared to others, expecting disruptive behavior, and were caught, and therefore those children were caught in the act of misbehaving more than their peers. These, I think, are tangible elements of work to show that the intangibles of how we engage with others based on race and ethnicity can go a long way toward adversely affecting them, their health, their legal issue concerns, and also educationally. Very often throughout my career, we recognize in educational settings, when persons are not managed correctly, some end up in alternative school or being sanctioned in DLC type settings versus Department of Mental Health. And also, I think very often in legal settings, we see these areas, I think, of maltreatment occurring every bit as well. I'd also share that in 2013-2014 year, young Black boys composed less than 20% of all in preschool enrollment throughout our country, but nearly half of all those individuals who are suspended, in many regards, expelled or sanctioned in a legal-oriented type way. So clearly, this process starts very early, has a remarkably adverse impact on these young individuals. I think we send messages to all, be it the young Black and browns, but also other individuals of the majority population, to be thinking and mindful and prejudiced in their perspective about those individuals, and that actually can carry out through other school age years and other type settings. Next slide. We also see these problems in the job market economically. This slide shows that compared to Caucasians, Blacks are twice as likely to be unemployed and earning up to 25% less when employed. Only imagine, I think, the emotional level of distraught that actually occurs. In my own personal life, my paternal grandfather, Vince Bailey, had that experience. Went to the U.S. military after finishing high school, got a good trade as a mechanic, came back to Beaumont, Texas, hometown, and told a story of many years that he would never allow to work as a mechanic at the one motor parts store in town. He had to work as a janitor, earn less money, but often will do the work as a mechanic. Imagine the degree of clinical depression that could actually cause. To be a psychiatrist to appreciate that, but just the low self-esteem and the insecurity one might experience going through life with that type of circumstance. So when a person has an adverse conflict, whether it's with the law, or whether it's drinking too much alcohol, or whether it's being arrested, and we only focus on the endpoint concern for that individual and not look upstream and recognize what may have been some of the antecedents that may have led to those problems, I think we missed the point. And that's why I think that Sheila Thorne's point earlier was very well taken. There does seem to be a revolutionary change now, in at least how we're able to talk about these things. I think in many settings, we're having a renaissance, so to speak, of an ability to think about and talk about in public domains, in panels and conferences, these areas, I think, of structural mistreatment of individuals based on being Black and brown. I think that has remarkable importance for us as we try to work to develop strategies to make effective change in this regard. This slide also shows that when identical resumes were presented, Black applicants' pictures were viewed much more negatively in hiring evaluations. And those identical resumes in this particular study were submitted and randomly assigned to be Black or white sounding names. We show that applicants with white sounding names, are 50% more likely to be called back for an interview. So that does actually seep deep into how we actually name our kids and whether we think about using initials and what do you have to put forward. There's been other communities, I think, in American society that have worked on changing their name to limit mistreatment and prejudice against them in attempts to get economic opportunities, employment, attempts to actually get into schools of graduate school and the like, to get the type of education that could lead to wealth development and wealth generation in their home and their family and their community. These issues, I think, make it very clear that there's an incessant and an inherent process that very often may be a bit subconscious, but acts out, I think, in a conscious domain that has adverse implications, I think, on young Blacks and Browns. The third or fourth slides that I'm going to show deals with the criminal justice system. As I mentioned, been involved in this for 20 or more years. There's a lot I could say, but I just pulled a couple points. One, jail sentences are similarly significantly larger and harsher for Blacks and Hispanics, Blacks and Browns than Caucasian individuals. Goes without saying that many of us are aware that until the Obama presidency, there was up to almost a 100-fold difference in the amount of time you could receive in jail or prison to be incarcerated if you caught with the exact same amount or arrested the exact same amount of crack cocaine as compared to powder cocaine. Our society has implemented a process where inadvertently Blacks and Browns tend to use more of the disposable crack form, and the laws follow to be much more punitive for those groups. I think that number got down from almost 100-fold to maybe less than 20-fold, but it never really got back down to being an even number. So clearly we have institutionalized the process that we appreciate which aspects of adverse behavior, and it is adverse. No one argues that a person should use crack cocaine, but the sentences should definitely not be differential and disparately adverse to Blacks and Browns in this setting. It was mentioned earlier by Black Lives Matter. Their protests were compared to attempted insurrection at the Capitol by a majority white crowd. Didn't make any sense at all. That Black and brown crowds of Black Lives Matter over the last year have been typically nonviolent and informational. Very often a lot of hostility and violence has come from other groups. But our society, our politicians, even at the U.S. congressional level, have had a difficult time, some of them, articulating this message and stating what we all can see live on television. In fact, I would hazard to say that if it was not for our witness with our own eyes live on television, the story and the narrative that we would have heard may have been very, very different. And that would have been much more consistent with what we've actually seen over the last century or 2 centuries that has led to the chronic mistreatment of African Americans, we gotta say Blacks and Browns in these settings over time. More discussion during the question and answer. Other points, the Atlanta shooter in that particular setting was stated by the white policeman to have had a bad day, quote unquote. The shooter of the church individuals in Charleston, South Carolina, his name was Dylan Roof, was quote unquote taken to a Burger King to buy a hamburger on his way to jail or prison. So a variety of aspects of the criminal justice system where we can see disparate treatment with harsher, more punitive sentences and a much more aggressive policing in Black communities. There's just been adverse in our society, and it needs to be called out and acknowledged for the wrongfulness that it actually employs. I'm always struck by cases that I'm aware of, and there was one case in Chicago years ago where as these police became much more militarized, they got military equipment, and they were really just very active in this process of the war on crime, and a group helicoptered into a housing setting. They meandered their way down ropes onto the roof. They shimmied down the staircase to allegedly go and break into an apartment complex of a person who they've been told by a supposed jail informant had drugs, non-violent, but had drugs supposedly. They break into the wrong room and they scare an African-American woman who lives by herself, not only half to death, but to death. She had a heart attack. They come in with tear gas, what have you, all ostensibly to find somebody who had, drugs in a possession, a non-violent, non-aggressive type offense. Clearly not making much sense at all in our society with how we over-police minority communities and how we overly militarize our use of our power of the American government against our own citizens who are African-American, again, and Hispanic. Last slide just deals with health outcomes. Last data slide, noting that area racism is measured by 196 designated areas as a portion of Google searches conducted, really containing the N-word. So the reality is we continue over years to use the slur and the N-word to dehumanize and undermine really the value of American citizens. Each standard deviation increase in area of racism, we know is associated with a 5% prevalence of preterm birth and a 5% prevalence of low birth rate among African-American children. So the reality is racism has a tangible impact on people. Women who are pregnant, the stress leads to more preterm birth. Families that are trying to deliver have a greater likelihood of risk, I think, of early mortality. Even African-American women having early mortality themselves during the pregnancy of maternal mortality. We're all very familiar with the case of the real famous and very wealthy African-American tennis player, Serena Williams, who almost died in childbirth. So there's some inherent stress and difficulty due to the constant plight of racism in our society that does have a remarkable adverse impact on African-Americans, males and females, those with money, highest, yes, and those without money, throughout, I think, overall system, which has adverse impact on health outcomes. I think I just finally point out that one standard deviation, greater level of racism, especially with an 8% increase in all-cause Black mortality in American society, at least about 30,000 additional deaths. So racism matters, mistreatment of people matters, and the unfair use of American government power, the American government resources to law enforcement otherwise, has a really negative impact on our American citizens who are Black and brown. I am saying why? Why does this have to happen? Fear, greed, and opportunities are given to minorities. So that those in power will lose their right, or lose their advantage, lose their power, or lose the ability to have a middle class life. The data doesn't necessarily show it. We could have economy. Our stock market is at 30,000 now. A century to get to 10,000, we're at 30,000. So to grow and for us all to win and to take care of ourselves and our family, we don't have to spend so much time in American society trying to hold one group down, theoretically, so another group can remain middle class. And also the ignorance of another's culture. By 11 a.m. on Sunday morning, being the most segregated hour in American society, it hurts us. By living separately, by working separately, the lack of integration in our society over years has also contributed to this constant plight of some groups thinking that they have to be superior to others in every particular type of way. Media, television, radio shows have also, like Cops is one show, reinforced this idea over time that some groups like Hispanics are regularly criminalistic in their action and must be treated so. Rather than using a healthcare solution, we use a legalistic type solution. Final slide, the more integral worldview, let's say for our citizens, institutions in which humanity is appreciated amongst all groups. Our educational system, our legal system, media outlets need to recognize these problems and really address them in a solution-oriented metric, rather than one that just continues to foster misinformation, prejudice, and bias in some groups. Dialogue, I note, is one solution to the problem. It should be encouraged. I think I mentioned earlier that seems to be better now than it was for some time. But I'm a 30-year psychiatrist. Our society has not really always been this way. I'm at organizations like the APA, the American Psychiatric Association right now, and they're struggling to find ways, hiring consultants to come in and help groups learn to work together, including on the board of trustees, for example. So they try to do better. I commend them for that. But imagine if a group of psychiatrists are having this struggle, how other groups may as well be having it as well. And the final point, the individuals must understand our own implicit bias and work to change that. In conclusion, I simply add that unless members of different races work to understand each other on an individual, personal, and group level, and realize they really share a common humanity, and that each really wish the same thing for our family, to be happy, free, and avoid suffering, the problem will continue to grow and worsen, and we very often will harm each other. And I think also our politicians have to be accountable, address the stereotypes, otherwise they'll prevail, and in many regards work to change this collective narrative to address collective implicit bias, tangible and intangible. Those are strategies I think that needs to be managed to develop, I think, some processes to improve American life for young African-American and Hispanic individuals. Thank you so much, and look forward to question and answer.
Dr. Bailey, thank you so much. Very, very enlightening. I learned quite a bit from all three of you during this opening part of the session. I do want to, before we move on to our next piece here, our next phase, where we're going to have a discussion and address some things, bring it down to more of a micro level. I want to remind the attendees, feel free to submit some questions here. You can use the Q&A function at the bottom of the screen. I encourage you to ask questions as we move on. As we get to the end, we'll open it up and we'll ask those questions of our panelists. What I want to ask the panelists right now, and don't forget to unmute your mics. This question goes out to all three of you. Sheila, in your presentation, you covered a broad range of things relative to systemic racism in our society. In addition to healthcare and policing, you covered, you talked about education and some other things. So we can clearly see that the overall issue here is still this issue of this broader platform of just racism. Now, obviously in society, we have no direct control over what people think and how they feel about someone who is different from them. However, when it comes to these systems of racism that cause these problematic issues in disparity, whether we're talking about wealth, whether we're talking about health, whether we're talking about policing and our justice system, as I mentioned earlier, you've got to have public policy that comes into play. So I'd like to hear from each of you, talk a little bit about, you can pick and choose the pieces of public policy that come to mind. But if you can comment on these pieces of public policy, whether we're talking about historical public policy, Giles, you talked about some of the things earlier dealing with Jim Crow laws and so on, but I'd just like to hear a little bit more about these pieces of public policy that play into these systems of racism here in our country. And
you want start with anyone in particular?
Start with anyone. You started, okay. Giles, so go ahead.
Yeah. Okay, very good. One of the pieces that I want to talk about is a very glaring example today of where bad public policy has impacted society in general, but also has had a devastating impact on the African American community, and that's going back to the crack cocaine era. Now criminal justice want to shift that model to deal with the people that also have substance abuse problems, such as opioids. They want to deal with that issue with a medical model. And let me go a little bit deeper into that. When President Obama was in the 21st Century Cures Act, a lot of people are not familiar with. It was signed into law December 13th in 2016. President Obama had approved the legislation after the Cures Act received strong congressional support from a majority of Democrats and Republicans in the House. The Cures Act aimed to improve health outcomes for vulnerable populations, including individuals with mental health issues and substance abuse disorders, and those who have recently been released from prison. Racial disparities in the criminal justice system have been well documented. It's not a point of debate, demonstrating that the communities of color experience harsher treatment than their white counterparts. Current research suggests that the United States is experiencing, as I just said, a growing opioid addiction crisis with high prevalence in predominantly white middle class and suburban communities. As a result, as I said, substance abuse is no longer perceived as a problem limited to urban community. So the Cures Act, it would encourage the decriminalization of substance abuse, offering public health approaches and engendering the potential to address the racial disparities present in the criminal justice system now. And what we need to do is to examine how countries outside of the United States have used public health approaches as alternatives to incarceration for those with drug addiction and other substance abuse problems. And I think that 21st Century Cures Act, if it was more aggressively applied, has the potential to reduce racial disparities amongst community of colors who have been disproportionately incarcerated. And subsequently recommend to legislators, providers, advocates, and members of the judiciary that they pay great attention to how also funding is allocated for these particular type of policy or legislation that's put into place.
Neil, I definitely feel your question is an excellent one, because in the work that I have done over the last 2 decades, definitely helps people to be educated about their needs and demand quality care. But unless public policy is put into place to really empower and mandate these changes is key. The one example that comes to mind quickly is the Patient Protection and Affordable Care Act, became affectionately known as Obamacare. I mean, the access issue, the fact that people of color did not have at least access, health coverage, so that they would get into a health system, could afford pharmaceuticals and other health products, was a major effort to make sure that we all had access. And yet that was politicized to the extent that it was clearly and still being trying to dismantle that. As a result of that policy, over 20 million people now have insurance who never had it before, predominantly people of color. So the question of access becomes a less onerous issue than it did prior to the Affordable Care Act. Regardless of your political persuasion, this now gives people who never had access. The expansion of Medicaid, the looking at Medicare, those are policies that really undergird people of color if they need help, and usually they get help very late in the process. At least they have now the policy that can support them going to a healthcare facility, speaking to a healthcare provider, and getting whatever pharmaceuticals or whatever other treatment they need. So very, very important that we become not only involved in the education, but the access and the policies to drive that education so people can take charge and control of their health.
Yeah, Ron, I'll just jump in, arguing, cannot agree more. Happy I wrote my first book about that very issue in 2013. And if anything, I'll argue that there's egg on my face now, because I could not have believed then, and still have a hard time believing, as Sheila Thorne points out, that there's been as much resistance to formation of the Affordable Care Act then and now. But if you dig down deep, it actually is not egg on our face, but I think egg on others, as we appreciate that the underlying racial conflict and bias, explicit, along with implicit, exists there. I'm a member of the American Medical Association, and to this day, many will argue that many will share with you that the biggest argument in the history of the AMA occurred on the discussion about the Affordable Care Act. The reality is similar to what you saw nationally in states that did not want to accept the ACA money. They're often southern states with large African-American, poor African-American populations. You saw within the AMA a very similar geographical divide, that the southern states, probably from Texas to Florida, and that U-horn of the southeast part of the country, were the ones that argued against it. Now, the AMA did something very different in 2013, if you will, or the like. It actually passed a resolution supporting the Affordable Care Act, with the exact same political process that happened in 1965 with Medicare, and then did not support it. So one reason I've been such a strong advocate, and I've known Sheila Thorne for many years in this regard, of the NMA, His enemies claim to fame was then and remains. It was the only major medical organization in the country to support the Medicare Act of 1965. And we've seen the exact same politics and politics of resistance and politics, I think, of the divisiveness concerns, limiting opportunity for healthcare and education based on race and ethnicity, and it very often has been worse in certain regions of the country than others. What I think is very unique now for many of us is we're seeing pockets in all 50 states. So it's not just the South versus the North. There are components of all 50 states where these areas of resistance and bias and mistreatment of others tend to exist. I'm out in California at times now, and in Beverly Hills, there'll be a march, and they're waving Confederate flags and arguing. Let's go back to the what I call the bad old days. So we've got a lot to do in this regard, I think, as educated professionals, to get the message out and to really craft a new narrative. And my final point on this issue, there's a lot to say, is that I think that until we can make the argument that fairness and equitable healthcare and education is beneficial for poor whites, as well as for individuals who are Black and brown, it may be a difficult uphill climb to make. But the reality is, in my practice, whether I'm in North Carolina, I in Tennessee, as I'm going to Louisiana here shortly, there's going to be as much effort to take care of poor whites using Obamacare funds and ACA funds because of Medicaid expansion, which some southern states are beginning to reconsider. Louisiana took those monies, although many other southern states did not, as well as, I think, taking care of what has been the historical legacy of this adversity against Blacks and browns.
Now, let me tell you how that intersects with law enforcement. Thank you for that, Ron. The law, it's over 2,000 pages. I read it. My friends told me I needed to get a life. But when it first came out, I really wanted to see what it said, because there was so much negativity around the passing. Within that law, there are services, mental health services for formerly incarcerated. You now have people that come out of prison with addiction issues or mental health issues or a homeless. I mean, there's stuff in that law to give those individuals access that they never had before. So clearly, there again, the law enforcement, policing, and intersection happens so that you can stop recidivism and you can stop people, to help them become returning citizens and live productive lives. So yet again, health and law enforcement, policing cross.
So what I'm hearing relative to public policy is that we have public policy that has been extremely detrimental to Blacks, the people of color, right? And then we have the absence of public policy that could go a long way in helping to unravel some of these racist systems. And that could, well, and then you talked about a piece of public policy, the Affordable Care Act, which actually was moving in the direction of, making healthcare more accessible to people, right? So that they can manage and deal with some of their healthcare issues and give them access to the medical practitioners that they need. But then you have, whether it's personal feelings or whether it's politics and partisanship, then you have people, trying to sabotage that piece of public policy, at the local level, at the state and local levels. So it's really interesting, to hear about from you three, the coming from different directions regarding, public policy and the effects that it has with what we're talking about here. Another thing that comes to mind, regarding this topic is the word trust, right? So when we talk about, historically, when we talk about healthcare, and trust, the Black community trusting or not trusting the healthcare community because of the history, during racism, coming out of racism. And I want to hear you talk about that history regarding, healthcare studies and different things that have occurred regarding Blacks in this country. And then trust on the other side with policing that we're having a huge problem with, because number one, we can't solve violent crime. And I know, Giles, this is I'm kind of like looking at you when I ask this question. We can't solve violent crime within our communities without the cooperation of the community, And if that community does not trust the police, the police are not going to get the information they need. And I'd like for you to talk a little bit more on that. But the issue of trust in both of these areas regarding healthcare and regarding policing, and how that can either help or cause problems, or retard the issues, or solving these issues.
Well, I think, quite frankly, we working, and we're very we have this silo mentality in this country, and you have police and the criminal justice system over here. You have healthcare and another system over here, and the two never really intersect. You have community providers over here, and nobody ever really talks to each other to address these problems in a true collaborative way, and with the intent of the best outcomes. We tend to take what I call as a anecdotal or band-aid approach. And if we continue to go down that trail, it's going to be what I consider a self-fulfilling prophecy. What we need to look more closely at is bringing together community providers are very knowledgeable about the criminal justice system. We don't often give them a lot of credit for that. This includes the sequence of events, terminology, process, criminal justice system. Criminal justice process starts at the point of contact with a law enforcement officer. And those contacts may result in arrests, entry to the criminal justice system, including prosecution, pretrial, adjudication, sentencing, sanction, corrections, and understanding that criminal justice system can help community providers facilitate continuous and coordinated treatment and services for justice-involved individuals, which I like to call them, especially those with mental health and substance abuse disorders. And if we clearly get a good understanding of this and how they interact with each other, also would help us to help providers know where in the criminal justice system and with what criminal justice personnel their client is currently involved with. It would help them deal with that problem in a much better way. And understanding the system also helps community providers recognize where opportunities exist to divert clients into treatment versus into the criminal justice, and take them out of that criminal justice system, which we all know in most cases, and if not all cases, doesn't really provide those type of services. And I just wanted real quickly to touch on the other thing that you talked about. We're in a space right now in my 35 years in criminal justice and law enforcement, more specifically, that there's a gap between the community and the police, and the community is no longer looking at the law enforcement community as being legitimate. And until we can rebuild that trust and then again become that legitimate entity, it's going to even make that much more difficult for even those interactions to even happen. And I'll leave it at that point. But we have to work more in a collaborative way, with healthcare providers, with law enforcement, and with community providers, other community providers. We have to be at the same table and address this in a very comprehensive way to divert specifically people from the criminal justice process that, quite frankly, should not even be there to start with, in my opinion.
Right. And Giles used the right word, build trust. This is not an overnight process. This has been festering since colonial times with regards to people who come from a different place, who speak a different language and who look different. So from the first time the slaves set foot in 1619 in Virginia, this ignorance about cultural differences and celebrating cultural is continued unabated. So you have to start by building trust, and you do that by relationship building, by reaching out to these communities. They're hesitant to come to you. You've got to reach out to them. And that consistency, transparency, accountability is what's going to build the trust, which is a significant factor. People talk about the Tuskegee syphilis experiment with regards to Black people not volunteering for clinical research. It is a metaphor. It is not the most egregious form of medical research abuse, but it clearly is the one that has the most notoriety. And now with the pandemic, in terms of trying to find people of color for clinical trials, that becomes front and center. But we need to do more. What is the whole system of clinical research? What are the protocols? Where are the sites where people can go? The whole system needs adjusting to address the unique needs and concerns of these populations. And little by little, that trust becomes more apparent with providers, with the system, and with the person who's going to be participating. So that again has illuminated the lack of having people of color in clinical research, which makes a health provider hesitant. Will this drug work good? And will it be safe in everybody? We need to have that. But that's a conversation. As Giles said, it's got to be a collaborative dialogue that we initiate in community so that people can air their issues and concerns and hopefully get more informed about making right decisions. And for those who are not of color, we need them to be educated culturally, because I call them unconscious incompetence. They don't know what they don't know. So they've got to reach out to entities that give them that education. National Medical Association, Association of Black Cardiologists, National Hispanic. These groups are there. They live this every day with these patients. They need to be at the table with law enforcement to talk about these issues.
Three quick points for me. One, I'd say both panelists, I think, are right spot on with this idea that the misnomer of mistrust has become a metaphor. We're putting data right now, and I hope to get this published here in the next 4 to 6 months. Our data is very consistent. We have a large setting where I'm now providing vaccinations for COVID-19. We're doing up to 3,000 injections a day. And all of our feedback data makes it very clear that the problem with getting Blacks and Browns vaccinated is much more about lack of access than it is lack of trust.
Right.
So I just regularly blamed individuals, we blame the victim by not providing access, not providing quality opportunity, not providing the same means of ease to obtain the goods and resources of society that we actually need. Then we find ways to indirectly, metaphorically point a finger at those who are in many regards are in deficit from receiving those items. I think Sheila's point is also taken. It's not really just this one issue of Tuskegee. We had our country allowed the testing of the birth control pill on Hispanic women in Puerto Rico and many other areas of misdeed. So it's not a function of mistrust of any one bad event. We've had 400 years of one event after the other showing seeds of distrust from the government toward the African-American person and Black and brown persons. So of course one is going to find ways to defend themselves. And that just means you have a higher index of suspicion about what actually comes your way, because all too often it's not been done correctly. If schools and institute communities are not as well funded, if we're over policed and over militarized police, if rules are not followed optimally, if whenever there's an area of gray area in legal or educational or bank lending concerns, if they're done to the detriment of the Black community and Black persons, of course persons are going to be back on the heels and very receptive, less receptive to an initial outlay of an opportunity because they've had their wings clipped, so to speak, metaphorically again, in times of the past. But I also want to come to what is in the chat about white ignorance. I think that I tried to that piece earlier, and I hope we hit a key point. I think that Jesse Jackson, when he was president in 1984, talked about a coalition between Blacks, Hispanics, and poor whites, and he probably was ahead of his time, because the reality is one thing that's kind of kept Blacks down has been this idea that poor whites have thought that their health care and their access and their jobs are all going to be limited. When persons in states are arguing that they're for a wall. I'm from Texas. A wall in Texas is not going to affect high wage jobs that are going to India from going to Ohio. It's really a remarkable slew of hand to make some groups think that the wall that's going to prevent persons coming from Central America or Mexico is somehow adverse affecting their income. Those are the top, I think, of our food chain have been making decisions for a long time that have actually led to poor fiscal and economic opportunities for those who are poor or not optimally educated. That leads to the haves and have-nots. and very often it's implemented by having a law enforcement setting. So I mentioned slave patrols earlier. Could not have made a better comment. That has actually had a generative view over, I think, centuries, let alone decades in our society. So the reality is that we have a lot to say about these issues. I think increasingly the data supports, I think, this growing swell of an argument that really argues for fairness and equity in a society where all members should be treated equally and have equal opportunity. We should actually work to undermine the barriers to doing so, particularly when those barriers are government imposed and disproportionately affect people who pay taxes as well, but because of their race and ethnicity. These issues we can do better with, and we must do better going forward.
Mm-hmm. So just so people know, the question that you answered and responded to, Dr. Bailey, so folks know, the question that was asked was, can we speak on the idea of white ignorance and how it has shaped some of the policies we've talked about and how it continues to shape policies today? And I think all three of you actually touched on that and actually answered that question as you went along. So thank you for that. You know, as we move to the end, we've got about 10 more minutes left before we wrap up. And, you know, I do want to hear from you before we close. Some of you actually spoke to some of the solutions, but I want to come back to that before we do close. In addition to some of the solutions, you know, this path forward, you know, what can and how can the attendees, the folks who are listening, some who may feel that, well, yeah, this is obviously a very serious issue, but what can I do? I'm just one person. I don't know anyone in Congress. I don't have connections here. I don't have connections there to, you know, regarding public policy or encouraging our policymakers to move in one direction or the other. So I want you to think about that as far as what we can say to the attendees, what advice we can give the attendees, and how they can contribute within their circles of influence. But I have to mention this before we do get to that, and it's one piece of public policy that I think, and it's currently beginning, but I think that it could have a far-reaching impact, and that is this piece of public policy regarding the prohibition and banning of menthol cigarettes within the Black community. Now, our attendees might be thinking, well, that sounds like a good idea, especially since we're talking about health, you know, in this session. But I beg to differ. I think it will impact not just our interaction between the Black community members and policing, because when you prohibit a very popular product, you just drive it underground into an illicit market. And we know what happens then. Community neighborhood competition in selling these products in an illicit market. The violence that comes with that, the distrust that comes with that, the police response to that, which we know can be devastating. But on the health side, when you move a popular product into a place of illegality, you know, then that product now becomes more unsafe for consumption because of how it is manufactured and how it's put together to satisfy the community need, you know, and doing this, you know, especially when you have an opportunity to, and you guys spoke about this, to improve, you know, systems of education regarding the consumption of this product, you know, to implement smoking cessation programs, which we know has proven to work, you know. So again, that's something that's coming down the road. I think it will be devastating to the Black community. Again, this emotional, unchecked, unresearched piece of public policy that's sitting right at our doorstep. So I just wanted to comment and mention on that real quick. And so if you guys want to comment on that, if you want to, go ahead.
My comments are that way exactly. I think it's hard to say it this directly, but I will. I think fool me once, shame on you. Fool me twice, shame on me. The Black community cannot fall, I think, for what's an unfortunate good cop, bad cop construct, that laws that criminalize behavior that is nonviolent. I said that earlier, that people engage in regularly. If you somehow criminalize it, is going to make it all go away. But you're exactly right. You're right. We have seen this movie before. Exactly what happens is we end up with, as the earlier speaker said, 3 million people in jail and prison in our society. On a given day, over half of all African men in Washington, D.C. are under some form of conditional release, probation or parole, because they were arrested before. Either they took a cop the plea to be out on probation, or they went to jail and got out early on parole because it was nonviolent in the first place. And then you end up just over criminalizing people. Then they can't vote, and our daughters don't have husbands to marry, and our communities don't have men to teach Little League baseball, all kinds of things. So no, I don't think it's a good idea to criminalize nonviolent behavior that disproportionately affects one community over the other one, especially the communities Black and brown.
You know, and Neil also too, and I'll talk to it from a law enforcement perspective, but here we go again. Okay, you would think by now we would have learned. If not learned, why don't we just follow the science? All right, why are we taking a public health problem and putting that already into a toxic criminal justice environment that we know is going to have bad outcomes? You know, for the life of me, I can't figure why we can't figure this out. You know, we know that the best two ways, and this is not anecdotal, science proves this. We know the best two ways to deal with anyone, regardless of whether it's tobacco, whether it's alcohol, whether it's any other type of substance, the best way to deal with that is through treatment and education.
Mhm.
That's science, okay? So why would we then? I just testified on this approximately a couple of weeks ago at the New Jersey, in front of the New Jersey Senate Judiciary Committee. Why would we then take that and did prohibition work? Absolutely not. Okay, not only will we make that interaction more toxic between a citizen, and specifically an African-American citizen, because that's what it's geared at, because the number of people that smoke that particular brand are African-American. And if there's no disparity between that and other types of cigarettes, why are we specifically focusing on that one? So, you know, we take these things, we don't give it the proper thought. And most times, I hate to tell you, unfortunately, there's not a diverse group of people around the table making these decisions as it relates to public policy. And that's why I would encourage everyone on the ground level. You know, politics starts at home, you know, and your local public policies will be impacting how law enforcement and other entities, even the healthcare profession, how they interact with your community. So get involved on a community level, and also try to, if you know there is some group, whether it's an advocacy group or a group that's a learned group, attach yourself to that group and partner with them so they could also support you on this effort, because they are strength in numbers.
Yeah, there's a continuum of advocacy, from self-advocacy to community to, you know, marching on the state capitol or marching on Washington. I think everybody's got to find their place in that advocacy continuum and own that. And the education, as Giles and Ron talked about, is so key. And that education goes out to the basic level. Neil, you know, I do cultural competency training of providers and community groups. And I'm talking about basic stuff. Do you call them African-American or Black? Do you call them Hispanic, Latino, or Latinx? I mean, they don't know even that level. Our educational system has not equipped the populace at large to understand the history and the dynamics of living every day as a person of color. They don't have that. So we've got to educate them with personal experience, with data, and make our decisions evidence-based, not a knee-jerk reaction to something that appears well-intentioned and appears to be good, but what are the consequences? What are the unintended consequences of these policies that you put into place to solve a public health crisis, and you put it in the hands of criminal justice practitioners? Doesn't make sense. While this nation is undergoing legalizing marijuana, now you're trying to make something that's been legal for decades illegal. Right. There's a very contradictory reasoning there that we have to talk out so that we don't hurt people more than they already are being hurt by policies that are poorly constructed.
Thank you, Dr. Bailey. I'm going to give you the, I'm going to go ahead, Giles, and then I'm going to give Dr. Bailey the last word.
Yeah, very quickly as it relates to law enforcement. You know, we're all the sum total of our life experiences. And if you don't experience something and you don't walk in somebody else's shoes, or you're not have a level of cultural competency, you can't identify with other individuals. One of the good things that Philadelphia Police Department does now is that when recruits come into the academy, they have to, it's mandatory that they go to the African American Museum in Washington, D.C. and get a tour of the history of people, the Africans that came to this country right up to present day. So, you know, experience like that will educate more people, I think are much more rewarding than many other things that we undertake in the academy. And we're pushing now to get those type of things implemented into the New Jersey Police Academy training curriculum.
Dr. Bailey, take us home.
My final comments. So this has been an excellent panel, outstanding panelist and moderator. Thanks for including me. I'd leave you with just 3 points. I think first and foremost, we need education. We need to be repetitive. We need opportune messages that focus, I think, on what the facts show, what the empirical data shows, and with that, keep pushing the message out in every possible media venue we have. So I thank you very much, Neil, for giving us this opportunity. We need more. Secondly, the reality is, I think professionals, whether we are physicians or lawyers and psychologists and law enforcement and others, I think we have a remarkable responsibility to our community to do the work and to produce the data so that we can actually support, I think, an academically based argument to craft a very new narrative going forward. I think others have actually crafted the narrative to tell their groups who we are. And we've got to do a better job telling all groups who we are and what we've done. This discussion, I think, was just made by about the African Museum is a very tangible point, I think, in that regard. And the third and final point I simply argue is that I think that our young people need to be encouraged early on to be proud of themselves and their activity, to recognize that I think that they have a responsibility going forward to be educated, to be informed, good, productive citizens. That's our expectations are of them, and we're going to help them do so, I think, in a very effective way in a safe, caring, and loving environment. Those have to, I think, be the best strategies going forward for our community.
Thank you. Thank you so much for a great session. I don't want to forget also the folks behind the scenes. Katie, thank you. She's our technical person behind the scenes. I want to thank Diane Goldstein, the new executive director of Law Enforcement Action Partnership, who's been working with us behind the scenes here. And I definitely want to thank the attendees for tuning in and the questions and just being willing to hear from these great panelists and to take some of this back to their communities, and hopefully we can make a difference going forward. Again, and I want to end with thanking the law enforcement and public health community for this opportunity to present on this during this conference. So thanks again, our wonderful panelists. Keep up the great work that you're doing, and we're going to make a difference. There's no doubt about it. So thanks, everyone.
Thank you.
Thank you, Neil. Bye-bye.